Welcome to Bookfulness. This is it, episode 39, our final deep dive in this pretty extensive series looking at clinically oriented anatomy, 8th edition.
It's been quite a journey, hasn't it? We've covered so much ground. Last time we were navigating the complexities of the neck, specifically all those vital structures packed into such a small space.
Exactly. The neck is that crucial conduit. And that naturally leads us, well, upwards to the command center itself.
To the brain's direct lines of communication.
Precisely. Today, we're tackling the 12 cranial nerves. Our mission really is to systematically unpack them, CN I through 12. We want to give you a functional, clinically relevant roadmap, drawing heavily on the summary tables and info in Chapter 10.
And these nerves are absolutely fundamental. They connect the brain to, well, everything from our senses, smell, sight, hearing, to facial muscles, swallowing, even regulating our internal organs.
So understanding their pathways, their functions, and what happens when things go wrong. It's not just academic.
Not at all. It's foundational for anyone going into neurology, surgery, really any clinical practice dealing with the head and neck.
Okay, let's get started. But before we just list them off, one by one, we need a framework, right? These nerves aren't all built the same way. They have different jobs.
That's the key. They have distinct functional components. When you look at Table 10.2 in the text, you see this variety laid out. We basically categorize functions into a few main types.
Like motor versus sensory.
Yes, but it's a bit more detailed.
Yeah.
You've got somatic motor, which controls skeletal muscles, like the ones moving your eyes or tongue. Then there's visceral motor, that's the parasympathetic system, controlling glands, smooth muscle. Think salivation, pupil constriction.
Okay, somatic motor, visceral motor. What about sensory?
Two main types there as well. General sensory, that's your basic touch, pain, temperature, pressure from skin, mucous membranes. And then special sensory, which covers the, well, specialized senses. Smell, vision, hearing, balance, and taste.
And most cranial nerves are a mix of these. They don't just do one thing.
Exactly. Unlike spinal nerves, which are typically a straightforward mix of general motor and sensory, cranial nerves are highly specialized. Some might be purely sensory, some purely motor, many are mixed, carrying several different functional components.
And knowing which components each nerve carries is crucial for diagnosis, I imagine.
Absolutely. The specific combination of functions tells you exactly what symptoms to expect if that particular nerve is damaged. It helps pinpoint the problem.
Right. Let's dive in with the first two then, CNI and CN2. These are kind of unique, aren't they? Purely sensory, and they connect directly to the forebrain.
They are. Let's start with cranial nerve I, the olfactory nerve. Its job is purely special sensory, specifically olfaction, our sense of smell.
And anatomically, it's quite delicate.
Extremely. You have these olfactory receptor neurons in the nasal cavity. Their axons gather together into about maybe 20 small bundles, the olfactory nerves proper. These tiny nerves then have to pass upward through numerous small holes, the foramina in the cribriform plate of the ethmoid bone. It's a very thin, sieve-like piece of bone separating the nasal cavity from the cranial cavity.
Okay, I can immediately see the clinical problem there. Tiny nerves, tiny holes, thin bone. Sounds like a recipe for trouble with head trauma.
It really is. Fractures of the cribriform plate, often from facial impact or head injury, are the most common way CNI gets damaged.
And the result?
The immediate result is usually anosmia, the loss of the sense of smell. This can be partial or complete, temporary or permanent. And losing smell significantly impacts case perception too, so quality of life can really suffer.
But it's not just about losing smell, is it? If that bone is fractured.
You've hit on the more dangerous complication. A fracture there breaches the protective layers around the brain, the meninges. This can lead to cerebrospinal fluid rhinorrhea.
CSF leaking out through the nose.
Exactly, and that's a direct pathway for bacteria from the nasal cavity to enter the cranial cavity, which puts the patient at high risk for meningitis. So it's not just a sensory issue, it can be life-threatening.
Wow. Okay, moving to the second specialized sensory nerve. Cranial nerve 2, the optic nerve, handles vision, obviously. But you mentioned something distinctive about this one.
Yes, and this is a critical point clinically. CN2 isn't technically a peripheral nerve like the others we'll discuss. It's actually an outgrowth of the brain, a CNS tract.
What does that mean in practical terms? Why does that distinction matter?
It matters because of myelin. The nerve fibers are myelinated, but the myelin sheath isn't made by Schwann cells, which myelinate peripheral nerves. It's made by oligodendrocytes, the same cells that myelinate tracts within the brain and spinal cord.
Okay, so it's structurally like the brain tissue itself. Why is that important?
Because it makes CN2 uniquely susceptible to diseases that attack CNS myelin. The prime example is multiple sclerosis, MS.
Ah, right. MS is a demyelinating disease of the central nervous system.
Precisely. So, inflammation of the optic nerve, optic neuritis often presenting as sudden painful vision loss in one eye, can be the very first sign of MS. MS typically spares peripheral nerves but targets CNS myelin, including the optic nerve, because of its developmental origin.
That's a fantastic clinical link. So, while other cranial nerves might get damaged by compression or trauma.
Which CN2 can be too, of course. Direct trauma to the orbit or fractures involving the optic canal where the nerve exits the skull can definitely cause vision loss and affect pupillary reflexes.
But it also has this specific vulnerability to autoimmune attack related to its CNS nature.
Exactly. That oligodendrocyte myelination is the key difference.
Okay, let's shift gears now to a group of nerves often discussed together, the ones controlling eye movements. CN3, 4, and 6.
The eye movers, yes. They all travel through the cavernous sinus and exit the skull through the superior orbital fissure to reach the eye muscles. This shared pathway makes them vulnerable together in certain situations.
Let's start with the main player. Cranial nerve the third, the oculomotor nerve. Big nerve, lots of jobs.
It definitely lives up to its name. Its main role is somatic motor. It supplies 4 of the 6 extraocular muscles, the superior rectus, medial rectus, inferior rectus, and the inferior oblique. It also lifts the eyelid via the levator palpebrae superioris.
So it handles most of the eye's movement plus opening the eye. But there's more, isn't there? The visceral component.
Yes, crucially, CM3 also carries visceral motor fibers. These are parasympathetic fibers. They go to 2 intrinsic eye muscles, the ciliary muscle, which changes the lens shape for focusing, and the sphincter pupillae muscle, which constricts the pupil.
And this parasympathetic function controlling the pupil gives us a really important clinical sign, especially in emergencies.
Absolutely critical. Think about a situation with rapidly increasing intracranial pressure, maybe an extradural hematoma, a bleed causing brain swelling. As the brain swells, part of the temporal lobe can herniate, pushing downwards. This herniating tissue often compresses CN3 against the edge of the tentorium cerebelli or the petrous bone. Now, here's the key anatomical detail. Those delicate parasympathetic fibers controlling the pupil run along the surface of the nerve.
Ah, so they get squashed first, before the main motor fibers deeper inside.
Precisely. They're more vulnerable to initial compression. So one of the very first signs of significant intracranial pressure and impending brain herniation is often on the same side as the pressure. The pupil starts to dilate and become sluggish, not reacting well to light, a blown pupil.
That's a massive red flag. Needs immediate action.
Urgent neurosurgical intervention, yes. The motor deficits, the eye movement problems, they usually follow if the compression isn't relieved.
And if the nerve is completely knocked out, what does the eye look like? What's the classic oculomotor palsy presentation?
The eye assumes a characteristic position often described as down and out.
Down and out. Why?
Because most of the muscles moving the eye up, in, and down are paralyzed. The only ones still working are the lateral rectus, controlled by CNGI, pulling the eye outwards abducted, and the superior oblique, controlled by CNIV, which pulls the eye down and slightly out, especially when abducted. So the unopposed action of these 2 muscles leaves the eye looking down and out.
Plus the eyelid issue.
Yes, you also get complete montyspasis. The eyelid droops shut because the levator palpebrae superioris muscle is paralyzed too. And of course, the pupil remains dilated and non-reactive.
Okay, let's move to the next eye mover. Cranial nerve third, the trochlear nerve. Much smaller nerve. Right.
Tiny nerve controls just one muscle, the superior oblique.
And the superior oblique's main action is?
It primarily intorts the eye, rotates the top towards the nose, and also helps depress the eye, move it down, particularly when the eye is abducted, looking towards the nose. Think about looking down and in, like reading or walking downstairs.
So a small nerve, one muscle, but its pathway makes it vulnerable.
Yes, it has the longest intracranial course of all the cranial nerves, and it's very slender. This makes it particularly susceptible to stretching or tearing during severe head trauma, especially with rapid deceleration injuries.
And if that superior oblique is paralyzed, what's the main complaint?
The patient experiences vertical diplopia, double vision where one image appears above the other, and this is characteristically worse when they look down and inwards, so going downstairs becomes very difficult.
Is there anything they do to compensate?
Yes, and it's often quite noticeable. To minimize the double vision, patients frequently adopt a compensatory head tilt, tilting their head away from the side of the paralyzed muscle towards the opposite shoulder. This helps realign the eyes to fuse the images better.
Interesting. Okay, the last of the eye movement trio. Cranial nerve the sixth, the abducent nerve. What's its job?
Very straightforward. Somatic motor to just one muscle, the lateral rectus.
Which does what?
Abducts the eye, moves it laterally, outwards, away from the nose.
Simple function. Is it vulnerable?
It is, mainly because of its long intracranial course near the base of the skull and its close relationship with the internal carotid artery, particularly as they both pass through the cavernous sinus, that venous channel beside the sphenoid bone.
So problems in the cavernous sinus like thrombosis, infection, or an aneurysm of the carotid artery could easily affect CND guys.
Yes, it's often one of the first nerves affected by pathology in the cavernous sinus. Also, increased intracranial pressure can stretch it as it runs up the clivus.
And the clinical sign of a CNVI palsy.
Very clear. Failure of the eye to move laterally. The eye cannot abduct past the midline on the affected side. This causes horizontal diplopia, double vision side by side, that is worse when the patient tries to look towards the side of the lesion.
All right, let's tackle the giant of the cranial nerves now.
Yeah.
Cranial nerve V, the trigeminal nerve. Tri meaning three.
Exactly. It has three major divisions, and it's the principal general sensory nerve for the face, scalp, teeth, nasal cavity, and mouth. Just massive sensory territory.
But it's not just sensory, right?
No, it also has a crucial somatic motor component, specifically for the muscles of mastication chewing.
Let's break down the three divisions, V1, V2, V3. Where do they go and what do they cover?
Okay, V1 is the ophthalmic division. It's purely sensory. It covers the forehead, scalp, upper eyelid, cornea, and the bridge of the nose. It exits the skull through the superior orbital fissure along with the eye mover nerves.
Got it. V1, ophthalmic, forehead, and eye region. What about V2?
V2 is the maxillary division, also purely sensory. It covers the midface, lower eyelid, cheek, upper lip, upper teeth and gums, nasal cavity, palate. It exits through the foramen rotundum.
And V3, this one's different.
Yes, V3 is the mandibular division. This one is mixed. It carries both sensory and motor fibers. Sensory covers the lower lip, chin, jawline, anterior 2/3 of the tongue for general sensation, not taste, lower teeth and gums. And importantly, V3 carries the motor fibers. It exits the skull through the foramen oval.
So knowing those exit foramen and superior orbital fissure rotundum oval is key for localizing lesions based on which division is affected.
Absolutely. A fracture or tumor at the base of the skull might selectively hit one or two of them.
Let's focus on the motor part of V3. We always say muscles of mastication. Which ones are those specifically?
The big four are the masseter, temporalis, and the medial and lateral pterygoid muscles. These are your main jaw closers and side-to-side grinders.
But V3 supplies a few others too, doesn't it?
It does. It also innervates the mylohyoid muscle and the anterior belly of the digastric, both involved in depressing the mandible and elevating the hyoid, plus two small muscles. The tensor veli palatini, tense is the soft palate, and the tensor tympani, dampens loud sounds in the middle ear.
Okay, so if that motor component of V3 gets damaged, what are the clinical signs? Sensory loss in the V3 distribution? Sure, but what about movement?
The key motor sign relates to the jaw opening. If you ask the patient to open their mouth wide, the mandible will deviate. It will swing towards the side of the lesion, the paralyzed side.
Towards the paralyzed side. Let's unpack that. Why?
It's because of the lateral pterygoid muscles. These muscles normally work together to protrude the jaw and control its opening. If the lateral pterygoid on one side is weak or paralyzed, the healthy, strong lateral pterygoid on the other side contracts unopposed when the jaw opens. This unopposed action effectively pushes the jaw forwards and across the midline towards the weaker side. The healthy muscle wins.
Got it. Unopposed action of the contralateral pterygoid pushes the jaw towards the weak side. That's a really important detail to remember, especially when we get to the tongue later.
Definitely. V deviates towards. Keep that in mind.
Now, Chapter 10 also discusses something complex involving CNV, the parasympathetic ganglia. CNV itself isn't parasympathetic, but it gets involved somehow.
Right. This can be a bit confusing, but it's clinically relevant for things like dry eye or dry mouth. Basically, parasympathetic fibers controlling glands in the head originate from other cranial nerves, namely CN3, CNE7, and CN nuts. These preganglionic fibers travel to one of four small parasympathetic ganglia located near branches of the trigeminal nerve. They synapse in the ganglion, and then the postganglionic fibers need a ride to their final target gland.
And they hitch that ride on branches of CNV.
Exactly. CNV branches act like a delivery service or a hitchhiker's highway for these parasympathetic signals. The trigeminal nerve provides the pathway, but not the original command.
Okay, let's quickly run through the four ganglia mentioned in Table 10.3. First, the ciliary ganglion.
Located in the orbit, presynaptic fibers come from CN3 oculomotor. Postsynaptic fibers travel via short ciliary nerves, which also carry V1 sensory fibers, to the ciliary muscle for focusing and the sphincter pupillae for pupil constriction.
Next, the pterygopalatine ganglion. Sounds complex.
It's deep in the pterygopalatine fossa. Presynaptic fibers arrive via the greater petrosal nerve, which originates from CN7, facial nerve. Postsynaptic fibers then hitchhike on branches of V2, maxillary, to reach the lacrimal gland, producing tears, and glands in the nasal cavity and palate.
Third, the otic ganglion.
Located near the foramen oval. Presynaptic fibers come via the lesser petrosal nerve, originating from CNIX, glossopharyngeal. Postsynaptic fibers then famously jump onto the auriculotemporal nerve, a branch of V3 mandibular, to reach and stimulate the large parotid salivary gland.
And finally, the submandibular ganglion.
Down near the submandibular gland, presynaptic fibers arrive via the chorda tympani nerve, another critical branch of CN7, facial nerve, which travels with the lingual nerve, a V3 branch. Postsynaptic fibers then directly supply the submandibular and sublingual salivary glands.
So a complex network, but the core idea is CNV provides the distribution network for parasympathetic signals originating elsewhere. Let's move on to cranial nerve 7th, the facial nerve. Another nerve with a lot going on, famous for controlling facial expressions.
Absolutely. Its primary function that everyone knows is somatic motor to all the muscles of facial expression. Smiling, frowning, closing the eyes, wrinkling the nose, that's all CNDs. It also supplies the stapedius muscle in the middle ear, the stylohyoid, and the posterior belly of the digastric.
But it's much more than just motor, right?
Oh, yes. It carries special sensory fibers for taste from the anterior two-thirds of the tongue, via the chorda tympani branch. It has a small general sensory component supplying skin around the ear. And, as we just discussed, it carries crucial visceral motor parasympathetic fibers for the lacrimal, submandibular, and sublingual glands, as well as nasal and palatal glands. A very complex nerve.
And clinically, it's highlighted as being the most frequently paralyzed motor nerve.
Yes, conditions like Bell's palsy, which is an idiopathic inflammation of CNDR, are relatively common. A peripheral lesion damage to the nerve after it leaves the brainstem, often near where it exits the skull at the stylomastoid foramen, causes paralysis of the entire ipsilateral, same side, half of the face.
What does that look like?
The patient can't wrinkle their forehead on that side. They can't close their eye tightly, orbicularis oculi paralysis. The corner of the mouth droops, they might dribble, and sounds might seem louder, hyperacusis, due to stapedius paralysis. If the lesion is more proximal, they might also lose taste on that side and have reduced tearing or salivation.
But the key clinical challenge is often distinguishing that kind of peripheral palsy, like Bell's, from a central lesion, like a stroke, right?
Exactly. And there's one crucial differentiating sign. It comes down to the forehead.
The forehead, how so?
In a central lesion, like a stroke affecting the motor cortex in the brain that controls the face, the lower part of the contralateral face is paralyzed. The mouth droops, the nasolabial fold flattens. But crucially, the patient can usually still wrinkle their forehead.
Why is the forehead spared in a stroke but not in Bell's palsy?
It's due to bilateral cortical innervation. The part of the motor cortex controlling the upper face, frontalis muscle, sends signals down pathways that cross over, but also pathways that don't cross over. So the forehead muscles receive input from both sides of the brain. A unilateral stroke might knock out the input from the opposite hemisphere, but the input from the same side hemisphere is often enough to preserve forehead wrinkling. The lower face, however, primarily gets contralateral input, so it's fully paralyzed by the stroke.
Whereas a peripheral lesion hits the final common pathway after all that input is merged, so the whole side goes down, forehead included.
Precisely. Forehead sparing strongly suggests a central UMN lesion, while complete hemifacial paralysis, including the forehead, points to a peripheral LMM lesion. It's a cornerstone of neurological examination.
Okay, let's move next door to cranial nerve 8, the vestibulocochlear nerve. This one is purely sensory.
Purely special sensory, yes. As the name suggests, it has two distinct components bundled together, the vestibular part and the cochlear part. They travel together from the inner ear through the internal acoustic meatus to the brainstem.
Cochlears for hearing, vestibulars for balance.
Correct. The cochlear nerve transmits auditory information from the spiral organ of Corti, in the cochlea, allowing us to hear. The vestibular nerve transmits information about head position and movement, linear acceleration from the maculae in the utricle and saccule, and rotational acceleration from the ampullary crests in the semicircular canals, which is essential for balance and coordinating eye movements with head movements.
What kind of pathology typically affects CN8?
A classic lesion is an acoustic neuroma, although it's more accurately called a vestibular schwannoma. It's a benign tumor arising from the Schwann cells, myelinating the vestibular portion of CN8, usually within the internal acoustic meatus.
And because it's in that confined space?
It compresses the nerve. Since it usually arises from the vestibular part, early symptoms are often subtle balance issues or disequilibrium. As it grows, it compresses the cochlear nerve, causing progressive unilateral hearing loss and often tinnitus, ringing or buzzing in the ear. If it gets large enough, it can even start compressing CNZ, facial nerve, which runs alongside it in the melissus, or even the brainstem.
And trauma. Can head injuries affect CNU?
Definitely. Head trauma, particularly concussions, can damage the delicate inner ear structures or the nerve itself. This frequently leads to vertigo, a sensation of spinning or movement, often accompanied by nausea and imbalance. It's a common cause of post-concussive symptoms.
All right, moving towards the back of the throat and beyond, let's talk about cranial nerve 9X, the glossopharyngeal nerve, another nerve with mixed functions.
Yes, quite diverse. It provides special sensory for taste from the posterior one-third of the tongue. It carries general sensory information from the posterior tongue, the tonsils, the pharynx, the middle ear, and the carotid body and sinus, monitoring blood pressure and chemistry.
What about motor functions?
It has a somatic motor component supplying just one muscle, the stylopharyngeus, which helps elevate the pharynx during swallowing, and it provides the visceral motor parasympathetic drive to the parotid gland via the otic ganglion, as we discussed earlier.
And it plays a key role in a very common reflex.
The gag reflex, absolutely. CNIX provides the afferent limb. Touching the back of the throat stimulates sensory endings of CNIX, sending a signal to the brainstem.
And the response, the gagging itself.
That's the efferent limb, carried primarily by CNX, the vagus nerve, causing contraction of the pharyngeal muscles. So, testing the gag reflex checks the integrity of both CNIX, sensory input, and CNX, motor output.
Is there a specific clinical condition associated strongly with CNIX?
Yes, glossopharyngeal neuralgia. It's similar in character to trigeminal neuralgia, but much rarer. Patients experience severe, stabbing, electric shock-like pain in the throat, tonsil area, base of the tongue, or even radiating to the ear. It's often triggered by swallowing, talking, or chewing.
That sounds debilitating. And what are the signs if the nerve is just injured, not firing painfully?
Injury would lead to loss of taste on the posterior third of the tongue, loss of general sensation in the pharynx on that side, and potentially absence of the gag reflex when stimulating that side.
Okay, let's move to its partner in the gag reflex and so much more. Cranial nerve X, the vagus nerve, the wanderer.
Indeed, it's the longest cranial nerve with the most extensive distribution. It supplies structures in the head and neck, but then it famously wanders down into the thorax and abdomen.
What does it do in the head and neck region primarily?
A lot. It provides somatic motor to most of the muscles of the pharynx, except stylopharyngeus, and the soft palate, except tensor veli palatini, and all the intrinsic muscles of the larynx. Essential for swallowing and speaking, it also has some general sensory function from the larynx and pharynx, and a tiny bit of skin in the ear, and special sensory for taste from the epiglottis region.
And then the wandering part, the visceral components.
Huge visceral motor parasympathetic outflow. It slows the heart rate, constricts bronchi, stimulates digestion, peristalsis, and gland secretion throughout the esophagus, stomach, small intestine, and large intestine up to the splenic flexure. It also carries visceral sensory information back from all these organs.
Given its control over the palate and pharynx muscles, how do we test for a vagus nerve lesion clinically?
A key test is to look at the soft palate and uvula while the patient says, ah. If there's a unilateral CNX lesion, the palate on the affected side will sag, and crucially, the uvula will deviate away from the side of the lesion towards the normal, unaffected side.
Okay, let's pause on that deviation again. Uvula deviates away from the lesion. Why?
It's that principle of unopposed muscle action again. The muscles that lift the palate on the weak side, supplied by the damaged CNX, aren't working properly. When the patient tries to lift their palate, the strong, healthy muscles on the normal side contract and pull the entire structure, soft palate and uvula included, upwards and towards the strong side.
It's like a curtain being pulled up and over to the working side.
Exactly. That's sometimes called the curtain sign. It's quite traumatic.
And because CNX controls the larynx via its recurrent laryngeal branches.
Damage to CNX, especially the recurrent laryngeal nerve, which can happen during neck or chest surgery, typically causes paralysis of the vocal fold on that side. This results in hoarseness, a breathy voice, and difficulty projecting the voice. Bilateral damage can be catastrophic, potentially closing the airway.
We're nearing the end of the list. Let's cover the last two, CNXI and CNX12, which are primarily motor, starting with cranial nerve LA, the spinal accessory nerve.
Or often just accessory nerve. Its function is purely somatic motor. It innervates two large important muscles, the sternocleidomastoid SCM in the neck and the trapezius muscle in the upper back and shoulder.
And this one has a really weird origin story, doesn't it? The spinal part of its name is literal.
It's unique. Unlike all other cranial nerves originating from the brainstem itself, the motor neurons for CNXI are actually located in the upper segments of the cervical spinal cord, C1 to C5 or C6.
So it starts in the neck.
Yes, the rootlets emerge from the spinal cord, bundle together, and then this nerve trunk ascends through the foramen magnum into the skull. Inside the skull, it briefly travels with CNX, and then it exits the skull again through the jugular foramen alongside IX and X to finally reach the SCM and trapezius muscles in the neck.
It goes up just to come back down again. Strange path. Does this make it vulnerable?
Very much so, particularly in the posterior triangle of the neck, where it runs quite superficially. It can be easily injured during surgical procedures like lymph node biopsies, or even from penetrating trauma like stab wounds.
And if CNS yotion is damaged, what are the consequences?
Paralysis of the SCM and trapezius. SCM weakness makes it difficult to turn the head away from the lesion against resistance. Trapezius paralysis is usually more obvious.
Right.
The patient can't shrug their shoulder effectively on that side, the shoulder itself droops, and they have difficulty abducting the arm fully, raising it out to the side, especially above horizontal, because the trapezius is crucial for rotating the scapula.
Okay, finally, cranial nerve 12, the hypoglossal nerve. All about the tongue.
Pretty much. Its function is purely somatic motor to all the intrinsic muscles of the tongue, which change its shape, and all the extrinsic muscles of the tongue, which move it around. Except for one, the palatoglossus muscle, which is actually supplied by CNX.
So CN12 is essential for speaking clearly and for manipulating food during chewing and swallowing.
Absolutely critical for both articulation and deglutition.
What's the telltale clinical sign of a CN12 lesion? It involves sticking out the tongue, right?
Yes. When you ask a patient with a unilateral CN12 palsy to protrude their tongue straight out, the tongue will deviate. It will point towards the affected paralyzed side.
Towards the paralyzed side. Okay, third time's the charm with deviation logic. Jaw V towards, uvula X away, tongue towards. Why does the tongue point towards the weak side?
It's due to the action of the genioglossus muscle on each side. The genioglossus is the main muscle responsible for protruding the tongue. When you stick your tongue out, both genioglossus muscles normally contract, pushing the tongue forward in the midline. If the genioglossus on one side is paralyzed due to CM12 lesion, the healthy, strong genioglossus on the other side contracts unopposed. This powerful contraction pushes the bulk of the tongue forward, but also across the midline towards the non-functioning flaccid side.
So again, the strong side wins and pushes the tongue over to the weak side.
Exactly. Unopposed action of the contralateral genioglossus. You might also see fasciculations, muscle twitches, and eventually atrophy, wasting of the tongue, on the affected side with a lower motor neuron lesion.
And there's a practical point about CN12 related to anesthesia.
Yes, a very important safety consideration. The genioglossus muscle is actively holding the tongue forward, keeping it from falling back and obstructing the airway. Under general anesthesia, all muscles relax, including the genioglossus. If the airway isn't managed properly, for example with an endotracheal tube or airway adjunct, the relaxed tongue can fall posteriorly and block the pharynx, leading to suffocation. Maintaining CN12 tone or compensating for its loss is vital during anesthesia.
So we've gone through all 12. Olfactory, optic, oculomotor, trochlear, trigeminal, abducent, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. Quite a list.
A crucial list.
If you had to pull one major theme from all the clinical correlations we discussed, drawing from that big summary table 10.6 in the book, What would it be?
I think the overarching theme is the power of precise localization. Because each cranial nerve, or even specific branches or components of a nerve, has such a distinct function and pathway, the clinical signs of damage are often incredibly specific.
You mean like loss of smell points directly at CNNI, or a down and out eye points right at CNI?
Exactly. Or the specific pattern of facial weakness telling you if it's central or peripheral CN7 damage. Or knowing that difficulty shrugging a shoulder implicates CNXI. These aren't vague symptoms. They often allow clinicians to pinpoint exactly where the lesion is along the nerve's path, whether it's due to trauma, a tumor, inflammation, stroke, or compression.
You mentioned compression several times. Can we use one final example that ties multiple nerves together, like the cavernous sinus?
That's a perfect example of anatomical convergence leading to clinical syndromes. The cavernous sinus, that venous structure sitting on either side of the sphenoid bone, has CN3, 4, V1, V2, and 6 all passing through or along its walls, along with the internal carotid artery.
So a problem there.
Like an aneurysm of the internal carotid artery within the sinus, or a thrombosis clot in the sinus itself, or even infection spreading there. It can affect multiple cranial nerves simultaneously. CNV's eye is often the first to go because of its position, but you can easily get palsies of 3rd, 4, and 6 together, causing complex ophthalmoplegia, eye movement paralysis, often with sensory loss over the V1, V2 distribution and significant pain. It highlights how understanding the anatomy of where these nerves travel together is just as important as knowing their individual functions.
It really emphasizes the intricate wiring and the vulnerability of these critical pathways packed into the base of the skull. Hashtag take C outro. And that brings us to the end of this deep dive, and indeed the end of our series. We've systematically worked through all 12 cranial nerves, looking at their functions, their pathways, their unique components, and importantly, the clinical signs that arise when they're injured. From anosmia with CNI to the patterns of eye deviation, facial paralysis, uvula movement, and tongue deviation.
It really is a masterclass in functional neuroanatomy. Understanding these nerves bridges the gap between knowing the structures and being able to diagnose the problems. Chapter 10 provides such a valuable synthesis of this critical information.
Well, this concludes our 39-part journey through clinically oriented anatomy. It's been incredibly detailed, covering everything from the back and limbs up through the thorax, abdomen, and pelvis, and finally the head and neck, culminating with these cranial nerves. A huge thank you to you, our listeners, for joining us on this exploration.
It's been a pleasure sharing this material. As a final thought to leave you with, just reflect on the sheer economy and precision of the nervous system, especially these cranial nerves. Think about how a tiny lesion affecting just a few fibers of one nerve can cause such specific and sometimes devastating deficits. Consider something as seemingly minor as losing taste on just the back third of your tongue from a CNIX issue, or a slight change in voice pitch from damage to a small branch of CNX affecting one vocal fold muscle. These aren't just curiosities. They can profoundly impact a person's quality of life, their ability to enjoy food, to communicate effectively.
It really underscores the incredible complexity packed into our anatomy and the immense skill required to diagnose and treat problems affecting these delicate structures. It's a testament to the importance of knowing this material inside and out.
Couldn't agree more.
Thanks for listening to Bookfulness.